Good morning, everyone, and welcome to the DeBakey Heart and Vascular Center Grand Rounds. We've got a great presentation this morning. And before I get to that, just a few housekeeping points. So, as you all know, watching here and everywhere, we want this to be an interactive hour. So you have the opportunity to submit any questions you have for our speaker, Dr. Kilic, and for discussion. You can join by text. Please type DeBakey to 37607. That's DeBakey to 37607, and then you can type your message or question. Or you can join by web. Go to polev.com, enter DeBakey, and then respond to the activity. So this morning, we are really honored to have Dr. Arman Kilic speak with us. To say Dr. Kilic is a rising star in cardiothoracic surgery would not do him justice. I would say that already his star is shining very brightly in the field of cardiothoracic surgery. He's currently an assistant professor of cardiothoracic surgery at the University of Pittsburgh, where I believe he went to medical school. He serves in many roles at the University of Pittsburgh. He's the associate director of advanced heart failure, where he does heart transplants, mechanical circulatory assist, and all kinds of complex cardiac surgery. He's also the co-director for the Center of Outcomes and Innovation in the Department of Cardiothoracic Surgery. Dr. Kilic did his medical school at University of Pittsburgh. He trained in surgery at Johns Hopkins, and then did his cardiothoracic surgery at the University of Pennsylvania, and has been at the University of Pittsburgh. He has almost 220 peer-reviewed articles, almost 220, and he's been in practice for certainly about 5 or 6 years. It's really an extraordinary career so far. So today, Dr. Kilic is going to speak about artificial intelligence and machine learning in cardiovascular healthcare. Just hype or the new frontier? So with that, Dr. Kilic, good morning.
Good morning. Thanks so much for those kind words, Dr. MacGillivray. So the topic for today is artificial and machine learning in cardiovascular healthcare. And this is something that I think really is going to have an exponentially rising role in how we do medicine over the next 10 years. Here are my disclosures. So really the objectives of this talk are to define artificial intelligence and machine learning, to debunk some myths about AI and ML, which is what I'll refer to for artificial intelligence and machine learning, to highlight some current applications of AI and ML in clinical medicine, and in particular cardiovascular healthcare, and to discuss the future of AI and ML in cardiovascular healthcare. So in terms of defining the terms, so artificial intelligence is really a broad term that refers to the ability of any technology or system to demonstrate human-like intelligence. Machine learning is a subset of AI, and it refers to the ability of machines to learn from data, to improve at tasks with experience, and to make predictions. Now, AI and ML exist in our everyday life, whether we know it or not. So everybody uses Google Maps or some kind of navigation software, whether it's in your car or on your phone. That is driven by AI technology, which can tell us the quickest route, can identify traffic patterns, and so forth. The middle picture there of San Francisco is with Uber and Lyft type of technologies where they can generate heat maps. These heat maps are actually based on, again, AI technology that can identify closest drivers, can identify fares, and so forth, and handle some of those complex interplays between multiple variables that determine which car gets sent to which customer and what the charged fare will be. Facebook and other social media platforms are increasingly using facial recognition. If you notice on your phone when you're looking through your photos and it can tell you which one of your family members is who and which one of your friends, and identify people, that facial recognition software is all based on AI. Siri. So Siri technology or virtual assistant technology is very much steeped in voice recognition and AI that's been around for decades. Credit card companies for fraud detection, I'm sure most people have noticed, fraud detection has gotten exponentially better in recent years, where you're not getting all these false alarms and getting called nonstop about charges, but really they've gotten much more accurate, and a lot of that is based on AI and so forth. And finally, if you do mobile deposit banking, for instance, with your bank, where you take a picture, that recognition of how much money is being deposited, where it automatically populates the deposit amount, that's all, again, based on AI technology. So if we take a look at the AI market in healthcare, as I've mentioned, it is exponentially rising and predicted to continue to rise. So around 2018, it was estimated to be about $2.1 billion. And by 2025, it's expected to increase by more than 15-fold to $36 billion. The panel on the right there depicts some of the startup companies that have been created in the field of AI in healthcare. And you can see they really range the entire spectrum of healthcare, from imaging to drug discovery, genomics, fitness and wearable technology, hospital decision support, predictive analytics, clinical trials, mental health, compliance, remote monitoring. So it really does span the entire spectrum of healthcare as we know it. So debunking myths. Myth one is that AI is new, that it's a new technology. And if you actually take a look at this timeline, artificial intelligence was actually defined back in the 50s. So in 1956, there was a research group that was formed at Dartmouth that looked at artificial intelligence and defining the basic terminology and how it may be used. And as you can see, since that time, there's been very sometimes popular examples such as IBM Watson, Deep Blue, which defeated Gary Kasparov in chess and so forth. But really, AI dates back to the 1950s. Myth number two is that all AI and machine learning algorithms are black boxes, meaning that we never really know how they come up with their predictions. This, again, is a myth. So if you take a look, there's a variety, really numerous different algorithms that are within the realm of machine learning. And some of them provide the same level of insight into their risk prediction as traditional risk modeling, like logistic regression. So on the left is a decision tree analysis, which is, an ML algorithm that basically can ask you very specific questions about the patient. For instance, their age, what's their ejection fraction, do they have diabetes, are they on dialysis, and so forth, and give you a rate of prediction of whether they'll have mortality or survival, for example. The panel on the right depicts extreme gradient boosting, or XGBoost, which is a very, very popular machine learning algorithm that actually will tell you with granularity the risk factors and what the relative importance of those risk factors are in the machine learning model. Myth number three, patients will never trust AI. My argument against this is that we already trust AI and we may not even know it. So again, going back to some of the examples where AI exists in everyday life, finances are a very personal thing and are very important to people. And that technology is already there to help detect fraudulent activity. So we're already in a way trusting AI. So hopefully I can convince you guys of this by the end of the talk. But I do think that by definition, we will trust AI when we see the results and some of the outcomes that can be achieved with this technology. Myth number four is that AI and ML can never perform tasks as well as physicians. Again, I leave this to later slides, but I will demonstrate that there are numerous studies and numerous examples that demonstrate not only this software being able to perform tasks as well as physicians, but being able to do it much quicker. Myth number five is that AI will put physicians out of business. So this, of course, is not the intent of this technology, nor do I think it is reality. I think that the way AI will play into healthcare is that it will be assistive technology, meaning it'll never be able to be a full replacement for physicians. However, it'll help in triaging healthcare and in allowing physicians to provide better and more efficient healthcare. So when we talk about applications of AI and ML in cardiovascular healthcare, I really like to think of three major groups of where these applications lie. And that would be in predictive analytics, automated imaging interpretation, and data extraction and quality control. So in terms of predictive analytics, we have a set of data or risk factors, and we're trying to predict an outcome based on those risk factors. This was a very interesting study that was able to determine the age and the sex of the patient using AI just from a simple EKG. And they were able to determine whether you are male or female with an accuracy that was over 90%. Again, this is not seeing any data except the 12-lead EKG. And they were able to determine the age of the patient if they were healthy within 7 years of their actual age with very high accuracy. And if there were comorbidities, really determining their physiologic age or in a way determining life expectancy. So this was a very eye-opening study where you get one basic piece of information and you can determine the age and sex of the patient with very high accuracy. Another technology that relates to predictive analytics is wearable technology. Again, many of you may be aware of this. Fitbits, iPhones that link to iWatches, and other kind of watches or rings even that exist now that can give you all sorts of information about your healthcare. This was a study that looked at predicting major bleeding after PCI. And table 3 that's highlighted here shows all the different models that were used and the C statistic. If you recall, the C statistic, which is the area under the receiver operating characteristic curve, ranges anywhere really from 0.5, which is a coin flip in terms of its predictive power, to 1, which would mean perfect prediction. And as you can see, the highest C indices were achieved with machine learning models, with a blended model with gradient descent boosting. And the panel on the bottom right there shows that it was a very well-calibrated model. Here's another study that looks at predicting acute kidney injury after PCI. And again, they looked at a variety of machine learning models as well as logistic regression, which I would suggest is our traditional risk modeling approach. And as you can see, there are statistically significant improvements in predictive capability with machine learning. Here's yet another study, this time in the realm of cardiac surgery, and this is looking at acute kidney injury after cardiac surgery. So what's plotted here is the area under the receiver operating characteristic curve. And as you recall, the more that curve bends to the upper left, the stronger the predictive performance of that model. And as you can see, the red bar clearly outperforms the rest of the models, and that's gradient boosting, which is a form of machine learning. This is a study we had done where we looked at all index cardiac operations performed at the University of Pittsburgh. And this is an interesting concept where the way we're sort of thinking about how to incorporate machine learning into some big data and risk modeling in cardiac surgery is not necessarily replacing the STS risk models with machine learning models, but trying to figure out why and how it is that they predict different levels of each outcome. And what does that mean when they agree versus disagree? So interestingly, in this paper, we looked at the patients who underwent index cardiac surgery and had operative mortality. And these dots represent each patient with operative mortality and what their STS predicted risk was and what the machine learning model predicted their risk to be. So you can see as highlighted by the orange bar, if you were to generate a random binary threshold, here we use 15%, meaning if the STS risk for operative mortality was 15% or higher, we're going to predict that that patient's going to die, versus if it's lower, we're going to predict that they're going to be alive. So if you set that threshold, you can see that there was 51 patients that were picked up as being predicted to die with the machine learning model, but that were predicted to live with the STS risk model. And you can see some of the dots where the STS risk model predicted them to have a less than 10% risk of death, but the machine learning model was predicting 30+% risk of death. Whereas if you take a look at the cases where the machine learning model predicted them to live, but the STS model predicted them to die, there was 26 patients in that cohort. And overall, the real takeaway here is that the correlation coefficient in patients who die is actually not great between the machine learning model and the STS risk model, with a correlation coefficient of 0.47, which suggests that there are real differences in how these models are coming up with their risk prediction. This was a study where we looked at over 240,000 patients in the National STS database for surgical aortic valve replacement. What we did is split the entire patient cohort into a training and validation set. And then we split basically into 3 equal groups that we use to define low, intermediate, and high risk. That obviously can be debated, what we clinically determine to be high risk or low risk. But this was a very objective and statistically sound approach to creating 3 equal sized patient groups, ranking them according to their risk and saying the top third are high risk, the bottom third are low, and those in between are intermediate risk. So if you take a look at this matrix, what it's showing you is the actual observed mortality rates in each of these groups in the validation set. So the interesting thing here is if you take a look at the gray shaded bars, those are the 3 areas where the STS model and the machine learning model agree with the level of risk of the patient. So when they both agree that the patient is low risk, you can see that their actual operative mortality rate is low. It's 0.66%. When they both agree that it's intermediate, you can see again, it falls within the range of what was defined as intermediate risk between 1.3 and 2.7%, and it's 1.55%. Similarly, when they both agree that the patient's high risk or over 2.7%, you can see again that the observed rate is within that range at 5.9%. Now, if we take a look at the other areas, the red bars or the red squares highlight the cases where the machine learning model was correct and STS model was wrong. So in 4 of those 6 discordant squares, you can see that machine learning was correct, but STS was wrong. And similarly, there was only 2 cases where the STS was correct, but the machine learning model was wrong. Again, basic takeaway here is this is using a very, very large data set of over 240,000 AVRs. And what it's showing us is that when the STS and the machine learning models agree on risk prediction, the confidence of prediction is very, very strong. When they disagree, it's not as strong. This was a study we did looking at, this was actually clinical trial data from the Endurance trial, which was a trial looking at the Heartwear HVAD left ventricular assist device. And patients were followed out to 5 years. So we actually took that data and we used hierarchical modeling and Markov modeling, or I'm sorry, hierarchical clustering and Markov modeling, which are various machine learning approaches, and created this graph, which is essentially a Sankey diagram. So a Sankey diagram is a very nice way of visually seeing what adverse events happen to patients. And I think this is really a nice way for clinicians to better understand some of the therapies that we're doing. So as everyone knows, you know, ventricular assist devices are burdened with adverse events, and they continue to be. And some of these include device malfunction, bleeding, infection, neurologic dysfunction, including stroke, renal dysfunction, respiratory dysfunction, right heart failure. Those are all the major adverse event categories that are defined by Intermax. And basically what this diagram shows is we're able to cluster patients into patterns that we notice based on their adverse event trajectories. So the column there on the left is their first adverse event, followed by the second, third, fourth, fifth, and so forth. And what you do is you can actually determine which patients tend to have similar clusters. And then prospectively, when you're evaluating a patient, you can assign them to one of these clusters that'll tell you what kind of adverse event trajectory they're going to have. So one thing you can notice immediately is that the majority of patients have bleeding and infection as sort of their first adverse event. That tends to be the first one that happens. And really, if you look at it sequentially, most of these patients have bleeding and infection throughout, meaning in terms of their first, second, third, fourth, fifth, those tend to be the predominant adverse events that occur. You can see that right heart failure tends to occur earlier on and then sort of dips down as you go into the fourth and fifth adverse event. And device malfunction, you can see a gentle climb where it becomes more prevalent further on, which again makes sense clinically, as devices tend to last at least some time before they start running into problems, including pump thrombosis. So I think this is, again, some of this is stuff we already know as clinicians who take care of VAD patients, but it's a very sound way to look at and develop visual analytics that help us understand the therapies that we're doing. This is in terms of smart pumps. So I do think this is the way of the future for ventricular assist devices. There's a lot of data that's contained and routinely collected in patients that undergo ventricular assist device. For instance, with the HVAD, we know the waveforms, the VAD parameters, and similarly with the HeartMate 3, we're always looking at the flow, the pulsatility index, RPM, so forth. This concept of ramp studies, ramp protocols, doing periodic echoes longitudinally after the VAD is implanted, you can imagine a smart system based on artificial intelligence that's going to automatically adjust these parameters, or that can notify clinicians of when there's an impending adverse event, such as worsening heart failure, stroke, pump thrombosis, etc. So Driveline infection, this was a neat study that was done where patients who were supported with a ventricular assist device took a picture with their iPhone and sent it. And it got interpreted into this AI-based software that was able to tell if there was a high likelihood of an infected driveline or not. So you can tell in terms of, especially in the current era with COVID and remote monitoring, how important something like this could be. So on to the next thing, which is imaging interpretation. So I think there's a massive role for AI and machine learning in imaging interpretation. So one thing is chest X-rays. This was a study that developed a deep learning algorithm and basically looked at a validation set of 420 X-rays and compared the ability of an AI software to determine all these various pathologies that you can detect on chest X-ray and compared it to 9 practicing radiologists. So you can see here, this is the C index with the radiologist and the algorithm, and it shows you who did better for each of these different pathologies. The algorithm was actually equivalent to the radiologist in 10 of 14 pathologies, better in 1 and worse in 3. But perhaps most importantly, and I think this is very, very eye-opening and really highlights the potential applications of AI in healthcare, the average time to interpret these 420 images was 4 hours for the radiologist and 1.5 minutes for the algorithm. So again, you're getting relatively comparable performance to board-certified radiologists, and you can see the striking time difference it takes to interpret these X-rays. Here's a study looking at EKGs. Again, a deep neural network was developed. They looked at 12 rhythm classes and over 90,000 EKGs from over 50,000 patients, and they compared it to cardiologists. So again, if you look at the, on the right side there, the F1 score, the closer to 1 that is, the better the algorithm. And you can see that for really the majority of cases, the algorithms performed better than your average cardiologist in interpreting these EKGs. Coronary CTA. So if we look at machine learning-based computational flow and FFR measurement versus computational flow dynamics, and again, the numbers highlighted in these panels are the C index. You can see that basically it is determining with very comparable accuracy how well the FFR is compared to computational flow dynamics. And here's the comparison of the C index for all these cases, and you can see that it's 0.84. So again, the curves are smack dab on top of each other. So this machine learning algorithm can perform just as well as computational flow dynamics in determining CT-based FFR. So there are some challenges to machine learning interpretation, particularly of video-based imaging. I would tell you this is sort of the new frontier in the ML world. There's been a lot that's been done on still images, so things like chest X-rays, EKGs, and so forth. The next wave of technology and research is really in video-based imaging. So this would include things that are relevant to us, such as invasive angiography. You can almost imagine, if you take a look at some of these studies that show us how many times in clinical practice a syntax score is actually calculated for multivessel coronary artery disease. Well, we know why it's not calculated, because the patients on the table were making decisions. We can sort of eyeball it. And we don't want to take the time to sit there and formally calculate a syntax score. And you can imagine a software that's immediately built in to the views that are obtained on the table and can immediately provide that level of input. Echocardiography, same kind of thing. You can imagine echocardiography reads that are done in an automated fashion using AI and ML. Some of the challenges, without getting too technical, with videos and ML interpretation, there are non-rigid deformations. So as you know, we're looking at flow, for instance, on angiography, and the walls of the vessel are going to move or get lit up with the contrast at various forms. Identifying vessel segments, there's different branch patterns with each patient. And the asynchronous nature of multiple view videos. So when you're moving C-arms around, you're going to get multiple views that may differ patient to patient and different respiratory patterns as well. And the majority of these studies, again, in imaging modalities have operated on still images. So one approach that's being done, including by our group, in the video-based imaging world is to actually take videos and parse them into millions and millions of still images, and then move forward with the research and identifying various segments of those images. Natural language processing is another application of AI and ML. So this was a study that looked at identifying heart failure patients of the electronic health record. The above shows sort of their processing engine for how they came up with extracted criteria. And you can see, again, the F1 scores. These are actually very, very reasonable and high F1 scores for determining whether a patient has heart failure or not, simply by unleashing an AI-based software into the electronic health record. And this is something that's very interesting to me. This study looked at basically the accuracy of providers' notes in identifying symptoms in patients. So the patients filled out a self-assessment, whether they were having a symptom or not. And the symptoms they looked at were chest pain, dyspnea, and cough. And then this study basically looked to see what level of documentation was done in the provider notes. So what you want to focus on is the kappa value. Again, kappa is basically an agreement value between the self-assessment by the patient and the provider's notes. The closer to 1 it is, the stronger the positive agreement. So you can see this actually highlights how poorly we actually do in detecting or documenting some of these symptoms. And then what the authors did is utilize natural language processing and looked at symptom documentation, and you can see markedly improved kappa values for each of those symptoms, going somewhere from around 0.4 to 0.6 up to 0.7 and above. In the operating room, AI is already used and will be used, I think, with increasing frequency. So again, there's different categories that I think of when I think about AI in the operating room. So anesthesia management. You can almost imagine AI clinical decision support for anesthesiologists, whether that's with standardization or not, or with error detection and limiting sentinel errors. OR efficiency. So I'll show you some technology where AI can basically predict the timing of a case much better and with much less resource utilization to help determine bed flow and so forth. Resident training. So you can imagine AI software that can really simulate the operating room and can provide very high level feedback to residents. Robotics, some of this technology is already in place. Cardiopulmonary bypass and perfusion management. We know very well from multiple studies in the literature that oxygen delivery, for instance, correlates very, very strongly with renal failure after heart surgery. So you can imagine adjusting flows, giving blood products, or giving volume or pressure or so forth to maintain mean arterial pressure based on an AI-guided feedback mechanism to the perfusionist, or even some level of automated or semi-automated management. Serious adverse event detection. So there's a lot in the literature about AI being able to detect very sentinel adverse events before they happen. And also taking a look at the OR environment. So there's some technology I'll show you that looks at video-based and audio-based analysis of the OR environment to detect what's happening and what can be done better. So again, in the upper left here is some of that technology. This was what's called black box technology, which basically takes video and audio, as well as everything going on with monitoring in the operating room, and can basically detect how many distractions occur during a case. And there was a paper published in the Annals of Surgery. It was looking not at cardiac surgery, but it was looking at general surgery procedures. And you'd be amazed at the number of auditory as well as physical distractions that occur in every given case. And this technology can help highlight some of those things to help improve efficiency in the operating room. The cholecystectomy that you see on the upper right there. So as the cholecystectomy is happening on the screen laparoscopically, the AI software is able to detect what phase of the operation it's in, and basically can immediately transfer that knowledge to the waiting room, can all immediately transfer to the charge nurse and so forth, and decisions can be made about bed flow and about notifying family. And then holograms for assisted surgery or assisted procedures in the cath lab is a very real thing with some very interesting technology that's being brought into the field. There are challenges in bringing artificial intelligence to healthcare. One of those challenges is legal. So the FDA basically is considering AI and machine learning as a total product lifecycle based regulatory framework, meaning that it's basically going to be considered as the same thing as a medical device from a regulatory standpoint. So this would allow for modifications based on real world learning and adaptation, but at the same time ensuring safety and effectiveness for patients. And this would allow the FDA to monitor this type of technology from pre-market development to post-market performance. There's also ethical challenges. So many AI and ML algorithms, again, are considered to be black boxes. As I highlighted before, there are some that are not black boxes, but there are certainly some algorithms that are. And there's limited insight into how they derive their models. So you could imagine for something such as cardiac surgery, where we're using the STS risk models every day in determining predicted risk. Well, what if you have a machine learning model and you have no idea how it's coming up with its risk prediction, but lo and behold, it's using race, sex, HIV status, or other personal health information to advocate against therapy for these types of groups? Well, that would obviously be a very big problem. The other challenge in AI in healthcare is trust. So I always think about the self-driving cars. Those are based on AI technology. And you can imagine, I mean, when a pedestrian or somebody who's riding their bike gets plowed over by a self-driving car, that's all over the media and it's a huge problem. Yet, if you take a look at the number of accidents that happen when humans drive the car, it's going to potentially far, far outweigh what these self-driving cars can do. But what will our threshold be in healthcare for mistakes by AI? And what if those mistakes lead to death of a patient? So putting it all together, one thing I will say is that the STS, or the Society of Thoracic Surgeons, has taken really a leading role in being at the forefront and trying to incorporate how we do AI and machine learning in the field of cardiothoracic surgery. The STS has already formed a task force on AI and ML specifically. This is a very interesting group that's actually comprised not only of cardiothoracic surgeons, but also internationally recognized experts in the AI and ML world. And I think that multidisciplinary approach is absolutely essential to getting the most that we can out of this field and applying it to healthcare. At the 2020 STS meeting back in January, there was actually a dedicated session on AI and ML with several very nice projects, many of which were using the national STS database, presented looking at AI and ML and how we can incorporate that into the field of cardiothoracic surgery. The STS also sponsored a video roundtable on AI and ML, which garnered a lot of interest and views. So I do think that the future really is in human and AI collaboration. Again, this is a field that's not new, this concept of collaboration between humans and AIs. It's been around for decades. But I think in healthcare, this is how the future will be. It will not be fully replacement of physicians, but it'll be assistive technology. So you can imagine wearable technology, for instance, with a variety of patient subsets that gives patient information or alerts physicians in terms of remote monitoring and so forth. In the imaging world, you can imagine a triaging system where, as I mentioned with that chest X-ray study, where radiologists need to figure out which ones do they need to look at first. So you can imagine if you run it through an AI software first, it can interpret hundreds of images in a minute and tell you, here are the 10 that likely have some kind of pathology. Well, that's going to help you triage some of the X-ray reads. And in the operating room, again, I think this is going to be what's called augmented reality, where you're going to have somewhat semi-autonomous systems. You're going to have a lot of video input and clinical decision support that's going to allow us to do operations better. So conclusions, I think the role of AI and ML in clinical medicine is exponentially increasing, not just in terms of the amount of research, but also innovation and the amount of money that's being spent in this field. There are challenges, ethical and legal included, to implementing AI in healthcare. And I do believe AI will be an assistive technology and not a replacement technology that will allow hospitals and clinicians to provide better care more efficiently. Thank you very much, and I look forward to any questions.
Arman, that was a terrific talk, very provocative, intriguing, and I would say in some ways shows us the uncertainty of what's going to be in medicine and healthcare moving forward. I remember when I took a computer class in college years and years ago, the professor said, garbage in, garbage out. And although I think our computer technology has advanced since those days, I think that principle still holds true. I mean, though, it's no secret that the electronic health record has all kinds of misinformation in it. And so those of us who have some experience can separate the wheat from the chaff. I mean, I presume that's something that artificial intelligence can do as well. I mean, is there any experience with that, or?
Yeah, I mean, I think that's a great point. And that's an absolutely right adage when you're talking about machine learning as well. Garbage in, garbage out. So a lot of how these algorithms are going to perform and ultimately what role they will play has to do with what kind of data they're working with. And so what I always think about is what is the end result? So, and again, this is almost analogous to thinking about surgery, right? There's millions of ways to do different parts of every single operation. And you almost want to think about, well, what's the end result? What's the mortality? What are the complications? Yeah. And, so if you're getting the same end result, does it really matter how we're getting there? And I think that it goes sort of the same way with machine learning. So I will tell you that it is still a work in progress. Some of these algorithms are not quite there yet where they're going to be able to do this at the same level as clinicians or experienced, providers looking at these electronic health records. But things that are getting more and more interest, for instance, in the cardiothoracic realm, you can imagine the amount of money and the amount of importance in data extraction for the STS databases, basically at every center in the country. And there's a lot of work being done, and it's sort of in the beginning phases of utilizing natural language processing to extract all the data that we routinely collect in these multi-center databases. And one question is the efficiency, which I think these, technology tends to be more efficient. So I think that'll be a check mark. And then the next question becomes quality. So what is the quality of the data extraction? And interestingly, and there were some examples in that talk, I do think that these algorithms will continue to get better. And the more data we feed into them, the more they're going to learn and the better they're going to get. And so I think they do have a way of sifting through some of that. I think we have to help them, right? So we have to obviously be at the forefront of this stuff. You can't just unleash a software and say, okay, figure all this stuff out. So that's why I do think that human AI collaboration standpoint is going to be very important. At the same time, I do think the technology will get there where it's going to be more efficient, it's going to be more accurate, and it's going to be able to do the things that we don't want to spend time doing. We want to focus on taking care of the patient and doing those type of things. And some of these automated processes, I think, can be done by ML.
We have a bunch of questions coming in, but just to that point, and at the risk of continuing with my old adages that I was taught when I was an intern is the way you get good at making decisions is by getting practice making decisions. And with these decision-making tools, it's easy for us to get kind of lazy in how we make decisions. And I could see that the more we depend upon artificial intelligence, the less opportunity that we'll have to go through the mental process of making decisions. And our ability to double check, cross check, the artificial intelligence will get less and less over time. Is that something that you think is accurate or just paranoia?
No, I think that that's a very relevant point. And I think that, again, ultimately, every decision made about a patient has to be made by a physician. And I think part of how this technology comes to real-world clinical practice has to be controlled by clinicians and by stakeholders. One thing where I think the role will be much easier to define will be in risk assessment and programmatic evaluation from a national standpoint. Because again, what I would argue is that it's relatively unfair if you have a model that's only moderately predictive and you're using that model to judge nearly every center in the country based on their performance. But what we're finding very interestingly is that when some of these machine learning models disagree with, let's say, the STS risk models, the prediction is not very reliable. It's a small subset. It's about 25% of patients. It's not the majority. And 75% they agree. And those predictions, I think, are pretty reliable. So that's the question, I think, and that's the more easier route of how we answer that question. I think in terms of clinical practice, we use it basically, again, as assistive technology. I think that's the way to go forward, where we figure out how can this make us either more efficient or provide us more information to ultimately make the decision. But I think those decisions ultimately absolutely need to be made by clinicians and not by this type of technology.
Let's get to some of the questions. Dr. Nasser, Kuram Nasser, asked, he feels strongly that there's, given the limited depth and breadth of registry data, that adding advanced analytics like machine learning probably doesn't add very much. He's asking what your thoughts are about, are there better opportunities with much larger EMR data or unstructured data? Is there more opportunity with that than with scrubbed registry data?
Yeah, I mean, I think one issue with that is protection of personal health information. So how do you get a lot of centers to put their data together, but do it without having to go through the entire rigmarole of IRB approval and, the whole thing of where you try to get a few centers together becomes a complete nightmare in terms of getting that data together. And how do you, like if you think about it in terms of the STS database or multi-center databases, how do you build some of this stuff without pouring in millions and millions of dollars and assuring good quality control of the data? Interestingly, one of the collaborators I have at Carnegie Mellon has developed a way that's a very streamlined way that absolutely can protect personal healthcare information with 100% guarantee and can facilitate data sharing between groups. So there's even applications, I would say, of machine learning and AI into that very granular sort of logistical process of data sharing. And I think some of these things and these guys have been thinking about this for decades. I mean, this is nothing new to them, but none of this stuff has been applied or tested in healthcare, but I think it has profound implications for how we can do things. And I absolutely agree with that comment. I mean, every time you look at a clinical trial, for instance, you're always thinking, well, this is a very narrow patient population. There's all these strict inclusion criteria. How does this relate to my patient that I'm going to see who has an MI, they're on dialysis, it's a different patient population than the trial patient population. Well, part of that is we have to take things from real world data. And I think that's absolutely the way forward. And I think some of this technology can not only evaluate the data once we have it, but it can facilitate massive data sharing at a very, very high level with millions and millions of data points.
So the next comment and question that comes in, AI continues to feel like science fiction. As its current state of investment in healthcare, we can barely even exploit simple technology like integrating Bluetooth blood pressure measurements or integrating CardioMEMS into Epic. What is the implementation science focus on AI in acknowledging these barriers?
Well, there are, and I think we're still, if you take a look at the entire spectrum of where we're at, we're still in the very, very early phase. So I think the thought processes, the technology and so forth has been there for decades, but putting it into a complex environment like healthcare, this is relatively brand new stuff. So not only how we implement it into the electronic health record, but how do we tackle some of the regulatory, ethical issues, so forth. And that's why I think it is absolutely essential to have multidisciplinary groups at very high levels at national organizations that are involved in this decision making. Because if we're not at the front of it, we're going to end up sort of chasing our tails after a lot of this stuff is already at the forefront. I also think that if you take a look, I mean, things tend to follow the money. And if you take a look at the AI in healthcare market, I mean, it is massively increasing. I mean, massively. And it's going to be over $36 billion within a few years of now. And there's already, I would say, well over 100 startups of AI with various focuses in healthcare, and it's just going to keep going, rising higher and higher. So at some point, I think the information and the technology is going to dramatically outweigh the implementation. But it's incumbent on us as clinicians and as key stakeholders to figure out how we want to implement that technology.
Another comment, great talk. I think that's a common sentiment. AI is a great tool for predictive analysis and clinical decision support. How can it be used to help decrease the ever exponentially I? I guess I stands for intelligence, but I think that maybe speaks to what I was asking before about, one of the things I found very striking in your talk was how poor we are at getting histories from patients. I remember a time when that was the most important decision tool that we had. And good clinicians were really good at it. They could ask the right questions and they could get from the patient the information that they needed. I guess the converse of that is, if we're going to expect patients to tell AI what's wrong with them, is there an interface between AI and the patients? Can the computer ask the patients the right probing questions to get from them the history that they need to make the decision?
I think so. I think there's already companies that are looking at that. And, what they're looking at is, you can imagine, it's almost like a Siri type device, right? Yeah. But in healthcare, like a healthcare Siri that basically can tell you. Now, there's obviously a lot of legal ramifications of that, but that type of technology certainly exists. It's obviously more complex than what's the weather today. But, that kind of stuff with the input of domain experts, meaning us. So there is absolutely that potential that you can have technology that has input from multiple physicians in terms of how we think. You can imagine sitting down with a technology developer who asks you, okay, run me through how you work up a CABG patient. And you just tell them everything you're thinking about. Usually we look at these patients in a relatively similar way. And absolutely, each patient's different. And we may look at different subsets or manage them differently. But that's stuff that's relatively easy to capture in some of this technology. Having said that, I still think that, the human element is never going to go away. Yeah. And that's something, even though I'm a big believer in, this is my focus, one of my focuses of my career. And so I'm a big believer in that it can make healthcare better. I think we have to be very careful that we don't lose sight of what it is we do. And I think, again, I would want the takeaway message to be that this is assistive technology. It's there to assist us to do a better job, but never to replace what it is we're doing.
So in the science of decision making, I remember there's deductive reasoning and there's inductive thinking. Just the gestalt and the judgment part of medicine. So does artificial intelligence help us more with the deductive thinking? Does it help us organize the facts that we have and weigh those facts in a logical way or a mathematical way to make the right decision? Or is it able to help us see the things that we don't commonly know that we see that are very important in making the decisions that we make?
Yeah, I think that, what it's able to do, and I would say it's able to do it better than traditional approaches like logistic regression, is it's very, very good at understanding the complex interplay that occurs between different risk factors. Yeah. So, for instance, a creatinine of 1.5 may mean less in a person who's 30 years of age and has endocarditis versus somebody who's 85 years old and has had a creatinine of 1.5 for years. Right. And those interactions between various risk factors, I think, are better understood by machine learning. I think also, there are times, I would say every day, if I see a patient, every day where I'm surprised what their STS risk is. I, as a clinician, and I've always wanted to do this study where you take a look, you give the patient information to a heart surgeon and you ask him, what is the STS, or what's your predicted risk of mortality for this patient? And then compare it to what the STS calculator shows. I think you're going to get a lot of discrepancy for certain patients. If you have an STS risk, for example, for an isolated CABG of 15%, that's extraordinarily high risk. But if you think about it, the calculator is telling you there's an 85% chance they're going to live, which we sort of know it's probably not true. It's probably more like 50%. Mm-hmm. And so there's certain things that I think it can provide us, whether we know it or not. It may say there's actually a relationship here. And remember, the machine learning algorithms, they have no emotion in the game. So, which can be a good or a bad thing, because you can say, well, that means they have no experience. But what they're doing is they're gaining experience from the data. They're picking up patterns, and that's what they're good at. And they can predict based on those patterns with relatively high accuracy.
Yeah. It's interesting, one of the challenges of registry data is it gives us information on the patients that we do something to. Do we do something to that person, whether it's an operation or an intervention? It doesn't really take into consideration the patients that you choose not to do something to. And so, there may be a small number or a medium number or a large number of patients who you've already decided are too high risk or they don't need to have a procedure done. And you're only making the assessment or the analysis on the small number of patients that you've decided to do something to. I mean, do you see that artificial intelligence will help us sort of factor in all of those, all of the patients that we assess and factor into those equations?
Yeah, so I think two comments with that. One is that I think that highlights the importance when we are doing some of these studies or when people are reading some of these studies, you want to make sure that it's a true apples to apples comparison, meaning if you have studies that are claiming that there's a machine learning algorithm that's better than an existing sort of gold standard risk model, you have to make sure that it's using the same exact type of data and in the same exact patient population as that pre-existing risk model. So what you don't want is to say, well, here's the pre-existing model, and then we used machine learning and we used every single data point we could extract from the electronic health record and develop the model. Well, of course, the machine learning model will be better in that case because it has more data. So a lot of the studies that have been done, for example, using national STS data, we've made sure to do that, which is we're using the same exact cut. We're looking at patients that have been operated on, as you mentioned, and we're looking at the same outcomes and so forth. Now, one thing I do think, and this goes more on the theoretical side, but to get to your point, I think that the way we do programmatic evaluation is suboptimal. So what we do is we take a look at procedures and we say, for that procedure, here's a risk model. What I think we should be doing is looking at a broader scale and saying, at institution X, what are you doing for coronary artery disease? So how many times do you do the right revascularization strategy, knowing the data we know or what would be recommended? What are the outcomes when you do select those revascularization strategies? And what are other metrics that really point, so it's more disease-based than it is treatment-based. Mm-hmm. I think that captures exactly what you're saying, which is you're taking a look at that entire patient population. It also takes into account what is the decision-making for therapy, which I think has a profound role in how the patient's gonna do longitudinally. And you could take that and extrapolate it to, it's the same thing as a heart team approach, right? So when you're talking about valve disease, okay, well, let's take a look at all the aortic valve patients. When are you doing TAVR? When are you doing SAVR? It helps also eliminate to a degree where it's beneficial some of the wide variability we see between institutions, which really is just local politics and just sort of how we approach things differently. Not that that's necessarily a bad thing, but once there's a level of evidence established that something is the right way to do things based on keeping evidence, I would say then you utilize that to look at a disease process and start doing programmatic evaluation based on the disease process rather than the treatment. That's sort of, futuristic thinking or maybe theoretical, but I think that's how AI and ML can help.
So I guess what you're saying is we take advantage of the benefit of machine learning and artificial intelligence to keep track of all of the rapidly expanding information that's available to us. But we're the ones that use that information when we interface with the patients and how best to use it when we're taking care of the patients as opposed to taking care of the information. Is that a fair assessment?
Yeah, it is.
Statement?
It is, and I think that one role would be that AI and ML I think has an absolute role in clinical decision support. So you can imagine if you're sitting, let's say you have a heart team for coronary revascularization, and you discuss every patient that's got multivessel disease. Well, you can imagine sitting in the conference room or virtually nowadays, and everything gets inputted into the software. And it basically tells you, here's the risk of everything with PCI, here's the risk of everything. And I'm talking about with very high granularity. So it'll look at the angiography, it'll look at all the clinical risk factors, it'll look at the surgeon that's gonna do the case. It'll look at the, cardiologist will do this. I mean, it'll look at everything. And it could tell you, okay, this risk of death in 1 year and 5 years is this, the risk of MACE or repeat revascularization or stroke. And it can really help with clinical decision support. I think that's one component. The other component would be if you pull all that data together in some type of national registry or data sharing mechanism, you can then start having implications of that in programmatic evaluation, where you say, in cases where there's a high syntax score, diabetes, XYZ, these patients should get CABG X% of the time if they don't have, let's say, these contraindications to surgery, for instance. And you can then start thinking about, well, how is this program determining therapy choice? And then beyond that, what are their outcomes? But, AI and ML can basically manage all that very complex data, I think, more efficiently and better.
So, I mean, the potential downside to it to the individual practitioner, and you mentioned it a little bit earlier in your talk, is, are we going to be replaced? I mean, is there enough information that the machine can learn that says, well, geez, you're not a surgeon on par with other surgeons, so you shouldn't be doing it, or the machine can read a chest X-ray better than the radiologists, and is that going to be used as is it going to be weaponized, I guess?
Yeah, I mean, I always think about, I think this is a broader conversation with technology in general. If you look at different robotic arms, for instance, that can, screw a tire onto a car in a car manufacturing plant. Before, people were doing all that. Now there's components of technology that can do the sort of repeatable, I would say, not mundane, but, repeatable tasks that you may not necessarily want to spend your time doing. Now, reading chest X-rays, again, that's, there's going to be certain components of that I think can be automated and can be done much more efficiently. But a role of that may be triaging, for example, where right now it's maybe a toss-up of how it gets triaged. And, instead of a radiologist having to do that, they maybe have time to do something else that's more, that's something they can contribute a relatively greater amount than reading a normal X-ray, for example. So I think, again, all of that and how it plays into it has to be determined by clinicians and stakeholders. Yeah. The technology is there. We just have to figure out how we want to utilize it. But I think it's the wrong thing to turn our shoulder to it and say, wait, this algorithm we know is reliably doing what we can in 1/100th of the time. And it's doing it as accurate as we are. I think we should take that as an opportunity and not be threatened by it and say, well, how can we utilize this technology and how can we make healthcare more efficient and how can we save dollars?
Well, I think that's a great summary right there, Arman. I want to thank you very much for giving us a great hour with a lot to think about. And I'd like to thank everybody who's tuned in to the DeBakey Heart and Vascular Center Grand Rounds. And until next time, stay safe. Thanks, Arman.
Thank you.